Appreciate that. All right, so we're going to talk about the disc for about, hopefully less than 30 minutes, maybe 25 minutes. Disc is something near and dear to me. I find it fascinating, and it still is the holy grail of pain medicine and spine. There's really yet to find any good solutions. Okay, thank you. Is it this one? Yes. Okay. So why are we interested in it? Well, it's prevalent. You can see here are 3 prevalent studies, Mantricani and Schwarzer, and most recently Michael De Palma from about 2011-2012. It's about 40% of patients with chronic back pain can be found to have the disc as the etiology. And the prevalence of the disc as the etiology changes with age, as, by the way, does the prevalence of other causes of back pain, including facet pain and SI joint pain. But prevalence of the disc as the pain generator decreases as you get older, although, of course, intuitively you know that degenerative disc disease increases as you get older. But the prevalence of facet joint pain and other causes of pain, such as SI joint, will increase as we age, as you would expect because of the changes that occur naturally in those joints and also in the disc. So degenerative disc disease is really a misnomer. It's age-related change. It's normal. None of us will escape it. If we are lucky enough to live long enough, we're all going to get degenerative disc disease. And it's related to changes in the composition of the nucleus and the matrix of the disc. There's loss of proteoglycan and water content, which eventually leads to the inability of the disc to do its job to resist compressive loading. Now, internal disc disruptions, a little subset of this that is not necessarily age-related, and it's related, specifically characterized by radial fissuring, and it seems to be associated with trauma or occupational type injury where you stress the end plate, you develop an end plate fracture, and that causes a reduction in water and proteoglycans, and ultimately delamination of the annulus and a reduction of pressure within the nucleus. If you can't keep the nucleus pressurized, you can't function well from a biomechanical status in terms of the function of the disc. So cyclic stress, that is just axial loading that is going through life, can precipitate end plate fracture. And it can happen even with physiologic loads. So basically, if you dig ditches for a living or that sort of thing, you're susceptible to continuous axial loading, and cyclic loading can precipitate failure of the end plate, which can precipitate these changes that I'm talking about. So we have a way of looking at this called stress profilometry that I'm going to go through that just gives you a nice depiction of what's happening in the disc when you lose the ability to pressurize the nucleus. Stress profilometry is what occurs if you place a transducer across the disc from posterior to anterior, and you measure pressures as you bring the transducer back across the disc posteriorly while measuring carefully the pressure. So you can see here that in a normal disc, the pressures are normalized throughout the disc itself. There's a slight bump at the posterior annulus, but it's really normalized throughout the entire intradiscal area. As you have injury to the annulus or to the end plate, you begin to lose the ability of the disc to hold pressure, as you can see in this diagram, and more of the pressure and force is transferred to the posterior aspect of the annulus where you see a spike. And over time, you fundamentally lose the ability for the nucleus to hold pressure, and all of the pressure is transferred posteriorly to the posterior annulus and the posterior elements, and you get failure of the internal bracing mechanism of the annulus, you get buckling of the annulus, you get tearing of the annulus, and characteristic radial fissuring. So fatigue fracture of the end plate precipitates the degradation of the nucleus and the nuclear matrix. You get a fairly robust inflammatory response, a decrease in the pH in this area, a biochemical insult, and dehydration of the nucleus, unable to accept and disperse loading. The load's transferred posteriorly, and eventually you develop radial fissuring. So here it is in a cartoon depiction that I borrowed from Nick Bogduck. You can see radial fissuring occurring from the nucleus out towards the outer annulus. You get circumferential fissuring, and then you get development of new blood vessels and new nerve fibers. And now you're set up for both chemical nociceptive input and also mechanical nociceptive input through movement or vibration. And this is measured in a scale that you can call the Dallas discogram scale. And once you get to grade 3 or grade 4, generally these are painful lesions, because that allows access of nuclear material to the outer third of the annulus where there is nociceptors through chemical stimulation of nociception, and also an excess load on posterior annulus allows for mechanical stimulation of those nociceptors. But all this is very important, and it's important to recognize these macroscopic findings. There are equally important things occurring within the microenvironment of the disc that maybe fundamentally we can change with some regenerative products or biologics, and that's the whole idea of the next 15 minutes of the talk. So these age-related degenerative changes are associated on imaging at T2 signal loss, but biomechanically, as I mentioned, they create depressurization of the nucleus. Macroscopically, you can see thinning and fragmentation of the annulus, and you get loss of a distinction between the annulus and the nucleus. You get fibrosis of the annular nuclear junction. You get cracking and tearing, and basically you get complete loss of the nucleus to hold pressure. So the nucleus normally, when we're young, is a gel-like matrix about the consistency of gel toothpaste that contains proteoglycans and type 2 collagen. And it's the negative charge of these proteoglycans that attracts and holds on to water, and that allows maintenance of disc height and load-bearing capacity. It's the job of the chondrocytes within the nucleus to synthesize and maintain this matrix, and there's always breakdown and buildup of new matrix, breakdown of old matrix, and it's this balance that determines the health of the disc. So it is a hostile environment. There's no direct blood supply, there's low oxygen tension, and as Jeff well knows, there's low pH. In fact, we worked for years to try to develop a very small pH probe that would go through a 22 gauge needle. We almost got there, but it was very difficult. That we could get one that went through a 20 gauge needle, but nothing that would go through a 22 gauge needle. We were hoping that we could add some objectivity to the subjective nature of discography by measuring pH at the time of the test. Nonetheless, a variety of insults can upset this homeostatic balance, and Jeff and I wrote a chapter about this about 10 years ago, probably, maybe longer, and none of this has really changed. Really, it's your genetics, metabolic disease, diabetes, smoking, and your occupation that lead to whether or not you're going to develop degenerative disc disease. So it's a balance of synthesis and degradation, and you can see this here again. This is Bogduck, and you want things to be on the curve to the right rather than the left. There's certain growth factors that, if present in the area of the matrix, will foster the chondrocytes to synthesize new matrix. And there's other catabolic chemokines and cytokines that foster degradation of the matrix. And it's a balance. And hopefully, if we are able to put the proper growth factors into the disc, we can move this towards synthesis and making new matrix and establish a new healthy phenotype for these cells and a healthier intervertebral disc. So we can look at this in two ways. We can either try to upregulate extracellular matrix proteins that increase anabolic activity, that increase growth, or we can try to downregulate inflammatory cytokines that increase catabolic activity. So if we can downregulate those, we can decrease the catabolic activity, and if we can upregulate the anabolic cytokines, we can increase anabolic activity to move things in favor of normalizing the environment in the disc. So can biologics slow or reverse this cascade? And if you transplant cells into the disc, will that improve the production of proper matrix and lead to better hydration and biomechanical properties? Well, there's some evidence, at least in vitro and in animal models, that this is the case, and there's some growing evidence even in human studies that we can achieve some of these goals. Let's look at animal data. This was a meta-analysis that was done by a group from Mayo, including Tim Moss, who is a radiologist, who's a very bright guy, looked at 6 RCTs in animals that met criteria. And they looked at the association between transplanting stem cells into the disc and whether that improved the height of the disc in these animal models of disc degeneration. And what they found is that overall, stem cell transplantation of the disc was clearly associated with a significant increase in disc height in all of the studies, and in none of the studies was there a decrease in disc height index in the transplant group compared to the control. And the increase in disc height index was significant statistically in each study individually and all the studies when considered together. So the findings of this meta-analysis suggest that cell therapy can arrest or reverse the degenerative disc process in animals. There was a meta-analysis done in humans, and I'm going to review this for you now. This was published in Spine in 2016. This was looking at a large number of studies, but out of the 1,300 or 1,400 studies studied, only 6 were of quality that were felt to be worthy to be included in the review. So they looked at 1,400 articles, and they only included 6 in the systematic review, and there were only 74 patients in those 6 studies. So we do have quite a bit of work to do in this regard to build a stronger evidence base. But nonetheless, in those 6 studies, if you look at pain score decreases after treatment, the decrease in pain score across the pooled studies, the mean difference was about 44 points on a 1 to 100 scale. And the mean oswestry disability decrease after treatment was also significant. The mean of the pooled data was 32 points in oswestry. So clearly, there was improvement in pain and improvement in function in these patients that were in these 6 studies that were systematically reviewed. And by the way, there were no adverse events reported in any of the studies, and no tumor formation observed in any clinical cases during the follow-up period. So cell-based transplantation therapy for patients with low back pain from the disc seemed to be associated with improvement in pain relief and disability index, but the protocol was different in each of the studies. There was quite a bit of variance in how they were carried out, and so there's no standard protocol for this treatment. What about other human trials? Let's quickly look at allogeneic trial. This is Mesoblast. We were involved with this. They have their own line of mesenchymal precursor cells that were injected into discs at 2 doses, 6 million and 18 million cells. You can see this is how the study was set up. They were followed up to 36 months. This is 12-month data showing you that in the blue and green, the treatment groups outperformed the pooled control groups quite nicely. 70% patients met 50% pain relief at 12 months. And if you look over to the far right, this is the group of strong responders. That is patients that essentially had 100% pain relief. There was a significantly greater number of these patients in the treatment groups than in the pooled controls. So the take-home points were that these allogeneic cells, they were not from the patient, they were from a universal donor, were well tolerated. There were no issues related to the use of an allogeneic product identified. And both doses, 6 and 18 million, showed improvement, but actually the 6 million cell group did better than the 18 million cell group, so there may be a dose-response curve where 18 million cells was too many. What about autologous MFCs? Let's look at this. This is a great study by Luis Orozco, 10 patients with expanded cells. These cells were harvested and then expanded for 3 weeks. and then injected back. They had 9 out of 10 patients with highly significant improvement. This is from Ken Patine. You've probably seen this presented before. It's a very good study, 26 patients, half of them 1, half of them 2-level patients. These were patients who were ready for surgery and decided to choose this study. At the end of 3 years, only 6 patients chose to go ahead with surgery, and of the 20 so patients that remained for evaluation throughout the study period, they did quite well. And you can see pain scores on the right, VAS scores quickly diminished and stayed significantly improved throughout the entire 36-month observation period. And ODI scores were also improved quite quickly. And in those patients that maintained in the study for the entire period, they had good relief throughout. If you look closer at the composition of these bone marrow aspirates, you'll see that the ones that had the higher cell counts, as I told you yesterday, if you had more than 2,000 cells per ml, you had a 90% improvement in your VAS, rather than a 48% improvement if you had less cells. Several of these patients showed improvement in their MRI after the study, which is hard to show. Only 6 of the patients went on to surgery within the 3-year period. How does this compare to surgery? Jeff showed you this yesterday. Overall improvement with artificial disc is about 57% in ODI, 63% in VAS. Fusion, 43% improvement in ODI, 52% improvement in VAS. And that compared to Patine showing a 71% improvement in ODI and 70% decrease in VAS. Other studies are available. This is looking at a leukocyte-rich PRP, a double-blind RCT of 47 patients. There was a statistically significant improvement in pain scores at 8 weeks. This is Levi. This is a double-blind RCT with leukocyte-rich PRP. At 6 months, 47% of the patients met 50% pain relief. This is an interesting study where the investigators did not just intradiscal, but also intra-articular and epidural injection at the same time. But you can't argue with the results. They're almost too good to be true. Pre-injection, the mean pain score was about 8/10, and at 6 months, the mean pain score in this group of 86 patients was 1/10. That was with intradiscal, intra-articular, and epidural injection of the biologic. Let's skip this and this and this, and let's go on to finishing. So the disc, degenerative disc, contains elevated levels of various things, including matrix metalloproteinases, interleukin-1, but bone marrow contains various things that can help with these products, alpha-2 macroglobulin and interleukin-1 receptor antagonist protein. So bone marrow is a multimodal agent. It contains various biochemical modifiers as well as cells and can take control of the pro-inflammatory environment of the disc. So MSCs do have the capacity to repair degenerative discs and differentiate towards chondrocytic cells and help native cells produce appropriate proteoglycans and type 2 collagen. And there is supportive animal and human data to suggest that this is the case. So lastly, I like this diagram because it basically informs you that the catabolic disc or catabolic joint has high levels of inflammatory mediators. If you pull the MSC into that environment, it can help support anabolic growth factors and decrease the inflammatory mediators, hopefully to restore a healthy anabolic phenotype to the native chondrocytes in the disc. And with that, I will close. I was going to answer Jeff's question about how do you combat carriage in terms of that article about does discography cause accelerated progression of degenerative disc disease. I don't have time, but it is in my slide set, and you'll get a copy of that. You'll be able to read it yourself. Thank you very much.